You are listening to the Horse Radio Network, part of the Equine Network family.
Welcome to this episode of Disease du Jour on the topic of equine tendon healing with Dr. Roland Thaler, owner of Metamora Equine in Davisburg, Michigan. The Disease du Jour podcast is brought to you in 2022 by Merck Animal Health. Dr. Thaler is a graduate of the University of Pennsylvania's College of Veterinary Medicine, and he's a diplomate in the American College of Veterinary Sports Medicine and Rehabilitation. He is ISOP certified and is a fellow of the College of Animal Chiropractors. His Metamora Equine is an ambulatory practice focused on sport horse medicine. Thank you, Dr. Thaler, for joining us today on Disease du Jour to talk about equine tendon healing.
Well, thanks. It's my pleasure.
Well, we know a lot has changed in the last decade in the availability of treatments for tendon injuries in horses, and we are going to talk about that. But let's first discuss the types of tendon injuries and proper diagnosis. So let's talk a little bit about some of the tendon injuries and maybe even by breed or discipline.
Sure. And I think this is a really good point in that, a treatment without a diagnosis has been compared to witchcraft. And I think Dr. Ken Allen has a better saying that it's more comprehensive than that. But regardless, it is important before we can expect any kind of success in treatment, we have to understand how the injury got there. And there are certainly different types of tendon injuries that are associated with different breeds and disciplines. And, the classic thoroughbred racing horse tendon injury is a core lesion in a tendon. And that's very different than a warm blood horse, which really has more of a degenerative change and a progressive remodeling. So, if we look at we have to ask ourselves why. And if we look at thoroughbreds, they're at the speed they're racing, they're really straining and stressing the tendon to its maximum capability. And from a biomechanical point of view, that when a tendon is stretched, the energy that goes in that tendon, most of it is recovered when the tendon snaps back to normal length. But if the tendon stretches 100%, the amount of energy that's returned back into the system might be 98%. So we have some energy that's retained within the tendon. And that retention is thought to be based predominantly in heat. So if they measure the center of these thoroughbred tendons, it's actually thought that the center of the tendon's heating up from the cycling of the stretch of the tendon during work. And it's thought that heat might actually be damaging the tendons. So that's kind of the thinking of why we have central core lesions in thoroughbred racing horses. Whereas in sport horses, warm bloods, we don't get that high speed cycling, but rather we get kind of a degenerative change where we have a lot of loading, unloading, and we get progressive breakdown. So we have to treat these horses very differently. And I should add that all the research that's in tendons is based on one of two models. One is a surgical transection, so to speak, or a surgical injury to the tendon, which is very different than either one of the two situations I mentioned previously, or more commonly is injection of collagenase, or an enzyme to digest collagen, which make up most of the tendon. And neither one of those two experimental models really simulates what's happening in the field. So we really have to take with a grain of salt what we're seeing in research, because it really doesn't match up well with what horses are doing in the field. So circling back around to this again, by breed and discipline, we look at horses at high speed, we get predominantly core lesions. And I guess you could also say maybe younger endurance type of horses are in that realm. The show horses, particularly the older dressage horses, seem to have a lot of degenerative changes. The location of the injuries, so not only the type of injury, but the location injury also changes, where the thoroughbred racing horses typically have an injury in the mid-metacarpus, as opposed to the show horses have a tendency to have more of a deep flexor tendon injury right above the navicular bone extending up into the pastern, or at the attachment, or what's called the muscle tendinous junction of the muscle to the tendon just under the back of the carpus. So I think those are the the two predominant presentations, and you have to excuse me because my practice is predominantly English horse or racehorse type of practice. I don't do many stock horses in this practice. There's a second group of horses that I'm suspicious about, and unfortunately we don't have a lot of information. It's been shown in a paper that Cushing's horses, or PPID horses, have dysfunctional cells that repair and are part of the suspensory ligament. To my knowledge, I'm not aware of this study being done on tendinocytes, but certainly it's been shown in the cells associated with the suspensory ligament. I would suspect that it probably has a similar effect in the cells of the superdigital flexor and deep digital flexor tendons. But what has been shown in the suspensory ligament is that these cells, with the influence of PPID, are unable to repair themselves and are somewhat dysfunctional. And I found that in horses. So I suspect that PPID probably affects the ability of soft tissue to heal itself. There is a group of older geldings in particular that present with a spontaneous disruption of the superdigital flexor tendon. So these horses are typically lesson horses. They're working every day or several times a week. They're sound, they're going fine, and then the owner will bring them out in the morning and the horse won't be able to walk and the tendon's big, and when you put an ultrasound on it, it's been disrupted. And there's really no event that occurred, therefore it's termed the spontaneous disruption. I would suspect those horses are probably a result of some impact of a metabolic comorbidity, and that hasn't been proven yet. But regardless, I think that's an important consideration. And I think as a final type of tendon injury, I think this compensatory overloading. I think Hillary Clayton had done some work where she showed that when there's an injury to one front limb, the compensatory structure is the superdigital flexor tendon on the opposite limb. So we can have compensatory injuries from one limb to the other side. And also to keep in mind that whenever we change the shoeing, particularly the elevation of the heel, we profoundly change the loading of the deep digital flexor tendon. So to the effect of about a 2-degree rise in the heel height will usually reduce loading of the deep digital flexor tendon by about 10%. So if some structure has to take that load, and that structure is either the suspensory ligament or the superdigital flexor tendon. So they have they are compensating for the tension that we're removing off the deep digital flexor tendon.
That's incredible.
It's interesting. Yeah. So I think there's a kind of an overview of the types of tendon injuries and impact of ages, work, and types of horses.
And I know you're an ICEL person, so I know our audience understands that diagnoses on these cases can sometimes not be easy. So what is it that you look for in your cases when you're trying to diagnose a tendon injury?
Well, I think, obviously we're looking for heat, pain, and swelling. And that's always easier if a horse has been sound, is young, and they come in from the field or after work and have heat, pain, or swelling. The thing that can be a little tricky about tendon injuries is sometimes that's not as evident the day that it happens. Sometimes that swelling and inflammation occurs the next day or two after the harder work. So what does make it confusing is that on an older horse, these older horses usually have multiple contributions to gait asymmetries or lamenesses. So, we might be looking at some coffin joints have some arthritis. We were looking at some hocks have arthritis, a little bit of a sore back, a little bit of a sore neck. So everything's a little bit sore. And then we have a tendon kind of sneaks in there, and that you have to be very careful with what you're calling. And, it's not uncommon for horses to have had a previous tendon injury that is thickened, that has remodeling that's evident on palpation or ultrasonography, but it's healed. So just because it's thick and enlarged doesn't necessarily mean it's the problem. So all that makes it kind of a conundrum or that we have to really sort out as veterinarians, right?
That can be a good point. So when you're looking at the history of these horses, what might clue you in that, hey, it might be the tendon?
I think I wish I had more histories. I think that if you have I think if you kind of correlate the workload to what the horse is currently undergoing, I think that is important. So, for example, if the horse had been jumping 3 foot and now the horse is jumping 2.6, and the horse is still relatively young, let's say less than 15 years of age, the likelihood of a tendon is a lot less than a horse that had been jumping 4 foot in a Grand Prix type of situation and all of a sudden mysteriously appears in your client's barn for sale for not a lot of money. And the new owners want to try jumping the horse again at that same height. So I think in answering your question, I think I would, looking at the history, I would look for performance demands that have changed. So if the horse is suddenly working at a higher level than it had been before, and with that associated higher level of performance demand, we start getting lameness, that makes me suspicious of tendon injury. The other thing I'll look at in history is if a horse has had repeated therapies to an area, for example, had been having a navicular bursa injected, coffin joints injected, a lot of perineural quote unquote blocking of the foot before shows, so that it kind of, or shockwave therapy, there's kind of been an indication that there's been a chronic problem in an area that'll make me suspicious that there might be a deep flexor tendon injury going into the foot or something along those lines. So we're looking at history, we're looking at performance changes. Well, I guess, surfaces too. So if a horse had been used to working on relatively firm surface and it suddenly goes to a horse show and it's very deep at that show, that makes me suspicious of a tendon injury. We have a lot of synthetic surface, so sometimes horses are at these shows for a month or two. I think they get acclimated to that firmer surface, then they come home to the deeper surface, or vice versa. I think also where I start thinking about more injuries occurring is the center of gravity of a horse is about 3 foot high, which, interesting, is about the height of most hunter jumps. So when a horse is jumping less than 3 foot, then really they're not really elevating their center of gravity. They're just transferring it from front to back legs on coming up to a jump and going over a jump. So it's a jump is really more of an extended canter biomechanically. Once they start getting above 3 foot, then their center of gravity and their mass needs to rise up. And so it needs to accelerate higher, and it needs to decelerate once it hits the ground on the other side. And it puts a tremendous increase of loading on the horse. And that's why you don't see near as many horses jumping 4 foot as you see jumping 2'6". So I think horses over 3 foot have a higher tendency to get soft tissue injuries in general, and it makes me a bit more careful around evaluating them.
That's a really good point. Let's talk a little more about use. So you were talking about performance demands at the onset of signs. So you think, when they maybe high speeds or jumping or something that's different in the stresses as a veterinarian.
Right. So, the beautiful thing about the horse's body is that it adapts to loads that are demanded on it. And as long as we give the body time to adapt, most times it can acclimate to that amount of load. But eventually, that amount of loading will start to fatigue the structure. And there's an interesting device. We have it down listed. We're talking about UTC, which is ultrasound tissue ultrasound tissue classification, clarification, characterization. There you go. So UTC is ultrasound tissue characterization, which is used in human and sport horse medicine. And it's kind of a movable ultrasound that reconstructs the fibers in the horse's leg in imaging. And people that use this, and it's used in human medicine and equines, but they can see that after jumping, that the fibers actually have swelling or edema between the fibers. And if you monitor it carefully, you can return that horse back to work when some of that edema is gone and dissipated. But if you continue to work the horses before they've had a chance to resolve that edema, then you get progressive breakdown. So, I think to some point in management, we need to be cognizant of that, because not every horse is the same. You can take a young horse and they're certainly much more agile, and they can jump. If they've been conditioned, they can jump and do quite well. Whereas an older horse starting to get other comorbidities or other injuries starting to catch up to them, they start getting swelling, they start getting more degenerative. And if we don't give them a chance to heal after that insult, it's going to progressively add up. We eventually will start getting fatigue and failure.
That's a good point. So let's talk a little bit about ultrasound, because that's a little tough, but it's a great tool to work on diagnosing some of these and following, like you just said, the recovery. So how do you use ultrasound in your practice?
So ultrasound is a fantastic modality. And the problem with ultrasound is that it's quite subjective. So basically, the sound wave, it goes out of the machine. And so the machine is literally a speaker producing sound. And then when it bounces back, the machine becomes a microphone recording the sound. And I tell people it's simply like standing in front of a wall and you're throwing a ball against the wall. And if the wall is solid and it's flat, the ball bounces right back to you with almost the same energy. And the machine will detect a sound wave in the same way and bounce back nice and bright. And when you have a flat piece of bone and ultrasound hits that flat piece of bone, bounces back, you get a nice bright reflection. But what if you're throwing a ball against a silo? So the ball hits a silo and it goes off at an angle so that you can't catch a ball, or if you do catch a ball, it's spinning at a bit of an angle, so you don't have quite the energy that it came back to you. And that's the same way when ultrasound hits a round structure, that it doesn't have quite the energy coming back. So where you hold the probe and how you position a probe will really influence the type of imaging you get back. So how I use an ultrasound is I use ultrasound to be perpendicular to all the structures as much as I can. And then I'll pick the leg up and I'll use the beam at what's called a COUS, which is angle contrast ultrasound technique, or off beam imaging, where literally now I'm holding the beam at a bit of an angle to the structure, and I want to see how much of it still reflects back, and it gives me an idea of linearity. So if I have a tendon, if I'm perpendicular tendon, it'll be nice, bright and white. If I hold the beam at a little bit of an angle, 15 degrees or even less, it'll be black. And so a nice healthy tendon will be white when perpendicular and will be black when a little bit off beam. A tendon that's been injured will have fibrous structure in it, and the fibrous structure is or the scar repair is typically not linear. So it doesn't matter what angle the beam hits it, it comes back at the same brightness or level of gray. So on an injured tendon, or a tendon that's had a scarring repair, I'll hold the beam at an angle and it'll be pretty bright white. And then when I hold it perpendicular, when I hold it at an angle, you'll start seeing a little bit of gray come back. And that tells me that tissue has been injured, probably has been repaired. And it gives me an idea of chronicity. So if I have an old lumpy tendon or enlargement of the tendon, I do the angle contrast technique, and then I can get an idea of that scar tissue, if that's newer edema. And so it gives me an idea of, is it acute injury, is it a chronic injury? So I think ultrasound is really, really important. I think that we don't, as veterinarians, we have a tendency to want to be static. So we want the horse to stand still. We want to put the probe on the leg and get a nice anatomic image. But I think the beauty in ultrasound is to evaluate these structures when they're moving. So I like to pick the leg up. I like to flex the ankle or the digit, and I like to see the tendons glide and the tendons move. And particularly, this is more important down lower in the leg than it is up higher. But I like to take advantage of things that are moving. At this point in time, it would be nice to capture these images in video clips. I think we can tell more from video clips, because it's always problematic to have another veterinarian send you images, because I tell people it's like taking a picture of a TV show and you just have one picture and it doesn't really give you a representation of what's going on. So I like to see short video clips. Unfortunately, the industry just hasn't grasped that yet, and we're just not there to really convey that in ultrasounds, but we'll get there eventually. Also, I'd like to see that the images are well documented. So often people will have images and you really can't use them in the future because they might have the horse's name, they might not, but they might not identify left or right or a location of the limb. Using zones is problematic. Traditionally, we say zone 1A or B, 2A or B, 3A or B. The problem is A or Bs are big areas. So what I like to do is I like to measure in centimeters from a joint margin. And then I can go back and I can say, okay, this injury extended from 6 millimeters distal to carpal metacarpal joint to 12 centimeters. And so I can write that in the notes. I can go back and find it.
Today's Disease Du Jour podcast is brought to you by Merck Animal Health, the maker of prestige vaccines, Banamine, Panacur, Regimate, Protozil, and other trusted equine health solutions. Merck Animal Health works for you and for horses. Learn more about Merck Animal Health's comprehensive portfolio of products, as well as their unconditional investment in our industry, profession, and community through programs such as the Respiratory Biosurveillance Program, the partnership with Equitrace, which delivers secure, streamlined record keeping and instantaneous temperature measurements when coupled with Merck Animal Health biotherm microchips. Visit merckanimalhealthusa.com for more information. So I think that's great. That's a great tip on the measuring. So when you're looking at these ultrasounds, what else are you looking at? At one point you mentioned the architecture. So what are you looking for as a veterinarian?
So typically I like to see size. And traditionally, if you look back in some textbooks and some papers written, they draw boxes around the structure, and they draw these nice rectangular boxes around a suspensory ligament or a superdigital flexor tendon and say the area is so many square centimeters. The problem is that there really isn't a box structure in a horse. So really what was being measured was the acoustic penetration through the contact area on the back of the leg. So you really need to see the full margin all the way around if you're going to measure that. So typically I'll take my ultrasound screen, I'll split it, I'll put the left leg on the left, the right leg on the right. So I always do both limbs. And I use the opposite limb as a comparison. So I want to see overall size. Now that's tricky in a practice like mine because I have a lot of older horses that are still performing. So oftentimes I'll have bilateral injuries, but still I think it's very important to have both limbs evaluated. So I'm looking for size change. Next thing I look for is architecture. And architecture is the shape of the structure and the fascicular structure architecture within the structure itself. And then finally, I look for the echogenicity. And like I said before, it depends a lot on how you put the probe, but I want to get an idea of the echogenicity and if there's evidence of nonlinear tissue within it. And, if you take all the horses that have a enlarged tendon, but no other signs, well, that could just be variation of the way the horse is made. Maybe he has a high foot on one side, low foot on the other side. He's a little different tendon architecture to accommodate that, and you're just looking at variation. If you have a horse that just presents with pain around the tendon, but no other signs, then he could have just hit his leg getting up, or his buddy could have kicked him in the field or whatever, and it could just be bruising, right? And if he has had changes in architecture, it could be an old injury and not really significant at this time. But if you have enlargement with architectural change and sensitivity with lameness in that leg, then it starts becoming pretty indicting. And I think that the Ian Fleming is, I think, the author of the James Bond series. And he said if something happens once, it could be luck. Happens twice, could be chance. Happens 3 times, the enemy's definitely operating. So I feel the same way with tendons. If we have enlargement, we have architecture change, and we have echogenicity changes, then we can start getting more reliability that what we're seeing is actually true and is actually the problem.
That's a really good point. So what else besides ultrasound might you use on some of these horses that have tendon injuries?
There are a couple different things that are out there. Probably the gold standard is MRI. And one of the things that ultrasound has been found in a paper that was just published last year that compared a CT, MRI, and ultrasound, that ultrasound really does underestimate, or as George Bush would say, my favorite quote is misunderestimate the severity of injuries. So, and you'll see that when you have a tendon injury identified on ultrasound and you put a needle into it and start injecting it, oftentimes you'll see the material that you're injecting go much further up the leg than you expected. So it is important to consider other modalities, particularly if you're in an area that you don't get good visuality of it, like the deep flexor tendon inside the hoof capsule. So MRI is a gold standard and is pretty reliable. CT with contrast can also be helpful, but it's underutilized. In the veterinary profession, we kind of went from ultrasound to, we have the CT thing, and we went right to MRI. Yeah. But now we're getting a resurgence in CT because CT is much less expensive, much quicker, and it can be pretty useful and pretty reliable. So I think that there's more interest in CT, and you'll probably see it come around more. We talked about MRI. Acoustomyography is a new modality. It's been shown to be useful for evaluating high suspensory injuries in a hind limb. It was pretty remarkable in that it could tell if an injury was there in a high suspensory or if it was healing. It could be gauged. It could gauge the healing and help return to work. The system is called Curo, C-U-R-O. I've been frustrated with it. I think my reliability hasn't been as good as I'd like it to be. It looks like there's some possibility that could be used for other types of tendon injuries besides a suspensory ligament injury. And right now it's just not being developed, or just not seeing much information on it. Also, people have used thermography for evaluating tendons. I've been frustrated with that because so often if a horse has a tendon injury, it's been poulticed, it's been sweated, it's been clipped, and all those things will affect how much heat is detected or the thermal signature. And if you put a little bit of a draft in a barn and they bring the horse in from the round pen and they're rubbing its leg with a towel before you get there, everything gets mixed up. So I found thermography to be incredibly insensitive and nonspecific. So I don't use it any longer. And there are other people who would disagree with that, but that's where I am with it right now.
And everybody has their own practice. Let's talk a little bit about complications. I mean, we discussed this just a little bit, but I wanted to return to this before because I lost a gelding who had PPID, and and talking to a lot of veterinarians, that's when I discovered what you have said, that they all feel like there is a link between the PPID and the tendon structures and ability to heal. So what about re-injury on tendons? Because we hear about that a lot.
Yeah, it's interesting. Something repaired is never as good as brand new, right?
Right.
And I think that's the way tendons are. And if you look biomechanically, look at tendon and transfer energy through it, we're trying to prevent the accumulation of scar tissue so we don't get concentration of stress. So whenever two dissimilar materials are bonded together, or at that junction will be concentration of stress. So if I just think of a rope that gets torn and you take the rope and you put it in a knot, you keep pulling on the rope. And where's the rope going to break? It's going to break on either side of the knot, not through the knot, but either side of the knot. So a tendon repair is the same way. If we have a repaired section of tendon, there'll be a stress concentration and a higher chance of re-injury on either side of that previous repair. So we have to be very careful that we try to rehabilitate these horses as much as we can to try to reestablish as much elasticity in the tendon structure. I think one of the most difficult things is that pain is the first thing that leaves as part of the healing process. And so coming into that is flexibility and strength afterwards. And as humans, we squeeze it, we look at it, well, it's not painful, we're going to put them back to work. And I think oftentimes they go back to work too quickly, and we're just rushing to repair beyond what it can take. So if we look at tendon repair, it really is in 3 phases. First phase is inflammatory phase, and that takes anywhere from a week to a month for the inflammation to settle down. The second phase is the proliferative phase, where the tissue comes in and starts multiplying and getting cells just goo into the area to start to try to get a repair. And that will usually take about 3 months to 4 months. Then after that is the strengthening phase, and that takes 6 months. And there's really not a whole lot to do about that. It just takes time. So if you start adding those together, on the best case scenario, if you figure a week for inflammation, you figure a month for proliferation, and 6 months for strengthening, so you're at minimum at 6 months for healing, even on the simplest injury. And if you go on the opposite side of that, you're a month for inflammation, you're 6 months for proliferation, and you're in at least another 6 months, if not longer. So you're well over a year. So the times that we tell people are really pretty true. And we can change the inflammatory condition of the leg very much. As I get older, I don't think that you can affect a repair of tissue unless there is inflammation. I think inflammation is very, very critical in the repair process. And sometimes I question, why do we spend so much time trying to reduce inflammation? Maybe we should be trying to encourage, or at least let it there to be part of the healing process. And if you look at the literature that says, okay, well, if we put corticosteroids into a hot tendon or a recent injury in tendon, surprisingly, I would think it'd be very detrimental all the way around. But surprisingly, the literature is kind of mixed. Some of these horses really do quite well, and other horses have delayed healing. So likewise, if you look at the effect of non-steroidal anti-inflammatories like Bute's been known to really affect or impact bone healing. So if there's a bone injury, we really don't want to be having Bute on board. Likewise, where they're in human medicine, where there's an enthesis injury, so wherever a tendon attaches to a bone, they usually try to discourage use of non-steroidal drugs because it impacts that. We could probably say that's probably true for horses also. And there's even some mixed literature that says that non-steroidals impact healing of tendons, and that's kind of mixed. There's some areas, some studies that show that it really does help, and other studies that show that it hinders it. So I think that probably too much inflammation causes further degradation. And I tell my clients that it's a little bit like when you want to remodel your kitchen. If you've had a fire in the kitchen, you have some inflammation, you want to stop the fire, right, before it destroys more tissue. Yeah. Then once you stop that fire, you have to clean all that material out, then you have to bring a lot of new wood in, and then you start to remodel that to make it look decent. And I think a tendon's not too dissimilar than that. So I think there is some part of the attenuation of inflammation that's probably helpful. So I do use some non-steroidal drugs in my practice. I do use ice in the practice to reduce the inflammatory component. And then once that inflammation settled down, then that's usually when I'll put in, or do you want me to go into what way I treat these right now? Or
yeah, I mean, this is what everybody's been waiting for. So let's talk about all these treatments that are available now.
So then once I get the inflammation settled down and the horse relatively comfortable, then I'll inject in my orthobiologic of choice if I feel it's necessary. And then I'll monitor that structure, particularly about 6 to 8 weeks. I'll monitor it because a lot of injuries, you look at them and they don't really look too bad, but at 6 or 8 weeks, all of a sudden they look a lot worse. And I think that goes back to, I think there's an inflammatory process going on. I think the material's degrading, and the lesion could look worse on ultrasound. I probably underestimated the severity at the first time I looked at it, but the process is going on. So I do like to inject these tendons if necessary. Then then based after that, I monitor and I want to see that the defect is somewhat healed with some sort of cellular type of material. I want to see some density come back on ultrasound. And then once I see that, then I start them in a rehabilitation program, because it's really important for these tendons, cells, to have stress and strain put on them so they can start to organize. So treatments. I'm a big fan of active rest. I don't like putting these horses in the stall, leaving them there for half a year. I think it's really bad for them. Mentally, their top spine. So I really think that walking is very good. And there was, I apologize, I don't have a good reference for the study, but there was a researcher had taken stem cells, they put them in a dish with no stimuli, and those cells proliferated in an unorganized fashion, and they didn't do anything. Then they had put a piece of string across another dish, and the cells lined up on that string. Then they would take that string and they would periodically pulse it, and then the cells lined up and started forming fibrous material and organizing along that string. And I think in the same way, when we have a tendon that's moving and cycling, it stimulates the healing in a more productive pattern. I think people get confused and they say, well, I want to turn my horse out for 6 months then. Well, turnout is not rest. So I really try to discourage turnout in a big pasture. I think we want to really limit the horses running. They say, well, I can't do that. I said, well, I let the onus be part of I let my client take that responsibility. I say, my goal is to keep your horse as quiet as possible and hand walk. You know the horse better than I do. You can find the conditions. I would suggest you do a round pen, small paddock, find a buddy that's quiet with the horse. But I think all those, we want these horses, I think it's good for horses to have a small turnout area. I think it's good for them to be walked. The rehabilitation of these horses, I think, is very important. And this might be tough to talk about, but I'm going to attempt it here. Typically, when we have and I'm going backing up into the therapies, because we talked about the rest or stable management, the rehabilitation. Typically, what we do is we say, okay, you're going to walk for 30 minutes for the first month, and next month you're going to walk for 30 and trot for 5. Then we're going to walk for 30 and trot for 10, and we kind of step it up each month. Every day they work a little bit more. So when you look at the graph of activity over time, it steps up. Does that make sense, Kim, when I'm saying that? So if we look at biomechanical loading, it is the area underneath that curve. So the way the step goes up, the bottom part of that, everything underneath that line, if you add up all that area, that's how much loading the horse is accumulating over that time. What I prefer to do is I prefer to pulse that. So I want to see little columns. So I want the horse to walk a little bit, then go back and walk a little bit more, then go back, then walk a little bit more. And the next time they'll walk, and then I'll put a short burst of trot, and then I go back to walk, and a short burst of trot, and I go back to walk. So my graph, instead of being a nice smooth step, is a step, but it's in spikes. Okay. So if you measure that area underneath all those spikes, it has half the biomechanical loading, but they're still doing the same activity. So we can stimulate these cells with the same kind of obnoxious stimuli of having to work for a living, but yet without fatiguing them. Because so often, by the time you get these horses right back up to where they were before, keep in mind that something repaired is never as good as brand new. If it broke before and you're doing the same amount of work, it's going to probably break again. So it's not uncommon to work these horses. You get them all the way up to the level of fitness, and then boom, there we go. It happens either in that leg or the other leg, or something else happens, and you have a re-injury. So what I tell my clients is I try to do this pulse type of workout rehabilitation, and that we want to reduce the intensity of work about 1/3 of what he'd been used to all the time. And then when they go back, they can still perform at that upper level, but they need to go back and get their training and conditioning at a lower level, if that makes sense. Yeah. And I think when I do that, I think that a lot of these horses can sustain that for a longer period of time. So the easiest thing for me to illustrate that would be maybe for jumping. So if I have a horse that's a 3-foot or 3-3 jumping horse, or even a 4-foot type of jumping horse, I'll tell them, do your training at 2.6, 2.9. Get your conditioning, get everything together. And then when you go to the show, then do the 3-3 jump, but then stop and go back to the 2.6 or 2.9 again. So let's go back to we talk about the rehabilitation, but let's go back to what are we going to put in this tendon to fix it, right?
Right.
So initially we were really excited about stem cells, right? We're going to take cells and we're going to suck them out of the horse's body and we're going to stick them in a tendon. We're going to grow new tendons. And we had the argument about, well, should we be using bone marrow? Should we be using fat? What's the best stem cell? Oh my God, we need to do this or do that. It turns out it doesn't matter. Because stem cells really don't grow. We're not really getting new tendon tissue growing, but rather the stem cells are providing cellular mediators of cytokines, and they moderate and modulate the environment of healing. So think of stem cells as being, there's a car accident on the road and the police show up and they have the tape and the sirens and the flares. That's what stem cells are doing. They're coordinating who gets into the area, who goes out of the area. They're moderating that entire process. Interesting, every horse has stem cells. They're floating all over their body. They're hanging around. I tell people they're like spiders hanging around, just waiting for something to happen. And that's not too unreasonable. It's a bit like the white cells in your body. They're hanging around all over the place too. But when you get an abscess or get a splinter in your arm or leg, then the white cells congregate to that area to clean it up. And it's the same thing stem cells do. Interesting about stem cells is that young horses at 2 years of age, if you take a teaspoon of fat, they have millions of stem cells, just loaded with stem cells. And if you take a 20-year-old, 25-year-old PPID horse and take a teaspoon of fat, they hardly have any. So when we say young horses heal better, it's probably related to that in some way or another. And that brings up another problem with stem cells is that if you're trying to fix a horse's body that's gotten an injury from chronic metabolism issues, you're getting stem cells that have been raised in that same environment, so they have what's called the same comorbidity. That might not be the best thing. On the other hand, then you're going to use you can use stem cells from a donor of another horse, and I don't know if that's, you can get away with that one time. You start using another couple doses of that, then you start dealing with the immunogenicity because you're stimulating that. So, stem cells they're exciting things. What we're finding is that if you take a population of stem cells and look at the surface of them, they're loaded with cellular vesicles. And these vesicles have little packets in them, and they have all kinds of wholesome goodness and different types of cytokines and functions. And a population of stem cells, each cell has its own little kind of thumbprint of different vesicle type. And we don't know which vesicles types are best for tendon healing. And there's a company right now that is marketing these cellular vesicles as a healing product. So that'll probably be something to keep an eye on. That might make a lot of sense. It might bypass some of the immunogenicity issues that we're having. And if we can get an idea of which cellular vesicle type, then we can concentrate and put that into that environment. That'd be interesting stuff to see. And right now, I'm not sure we're quite there yet. The other issue we have is a lot of these stem cells are grown on fetal calf serum. And fetal calf serum is wonderful stuff, but it's also what grows a lot of vaccines. So if you're injecting vaccines to stimulate immunogenicity, you're also stimulating against fetal calf serum, which if you're putting stem cells into a horse that has been recently vaccinated, maybe that wouldn't be the best product to use at that time.
Wow, never thought about that.
Yeah. And I don't think that's really widely, there isn't a lot of awareness of that, but I think I would have some caution with that. So that's where we are with stem cells. Now, currently the most common therapy people are putting in horses are platelets. And platelets are great because every horse has them. They don't seem to be they're not a kind of a cellular, as intensely cellular, so they I don't think they seem to be quite as affected by the comorbidities, but that I might be speaking out of turn with that. But certainly they're easy enough to harvest out of a horse. They're easy enough to prepare, and they're easy enough to inject in. Now we have a couple of problems with PRPs. We have no idea the best dose. So manufacturers tell us that we have a 3x or a 5x concentration. Well, we do know that if you have too high of a concentration, it's not good. If you don't have enough, it's not good. But we don't know what is good. And it's as simple as nobody really measures how many platelets they're injecting. So that to me is problematic. We take blood, we spin it down, and as you're injecting in, we say we would put 2.5 cc's of PRP in. Well, how many platelets did we put in? We have no idea. And I think we can move ahead once we get an idea of what our concentration of platelets are. And it would be simple enough to do. It wouldn't be too difficult to have some sort of test or smear that we could kind of count platelets easily and know that, okay, we're putting in, I don't know, 6 million platelets in this injection, but we just don't have that information. And so we really need to validate that. The other thing we need to validate is platelets sit right alongside the leukocytes. So the leukocytes are the white blood cells. If we suck up some of the platelets or some of the leukocytes with the platelets, then we call that leukocyte rich. And rich always sounds better. Nobody wants to be poor, but leukocyte rich has a tendency to be more inflammatory. So in general, when you put platelet products in joints or synovial structures, you probably want to go leukocyte poor. And when you put them in tendons, they stimulate a little inflammation. Remember how I feel about inflammation. I think that leukocyte rich has a tendency to be a little bit more pro-inflammatory. So I prefer. So when I make up a preparation, I have leukocyte rich or leukocyte poor syringes right in front of me, and depending where I'm injecting, if I'm not in a synovial structure, I'll put leukocyte rich. If I'm in a synovial structure, I put leukocyte poor because I don't want to stimulate an inflammatory response. I think that one of the studies in humans was measuring the effect of PRP in Achilles tendon injuries in humans, and they said it didn't work. And when you look back at the researcher, they were injecting the structure without use of ultrasound. So I thought it was kind of interesting that somebody would publish that, but I think it's important that we as veterinarians gain enough skill set that we can do this through ultrasound guidance. Because we don't want to be squirting this wherever we want to willy-nilly in horse. We want to put it into the lesion. And then I think that the biggest issue I've seen with putting platelets in a defect is how much do you put in? Because it's very easy to overinflate the injury, and you can see it dissect. Oftentimes when you inject in, you push a little bit of air in from the needle or hub matrix, and you'll see that flash up. And it's surprising when you inject in one area that you can follow that sometimes up 3 to 6 centimeters up the leg. Okay. So I think it's important to have ultrasound to see what you have. So I don't have a better way than just by feel. I look at the defect, and when I see it expand up, I figure I have enough. And it's a very subjective on my end. And I think that every veterinarian will need to get their own confidence level. You'll probably overinflate several of them and say, wow, that was a little too much. And then you'll learn to back off. Other therapies, shockwave has been interesting. I started using shockwave in about 2000, 2001. I spoke with the gentleman from Germany that started shockwave, Joseph Boning, and he had a kidney stone or bladder stone or urethral stone. He went to surgery, and they did lithotripsy and broke up the fragment. And when he got out, one of his cases he saw was a bony fragment at the enthesis of the suspensory ligament. So he thought he'd put shockwave on it to break up the little fragment, and the horse healed. And at that time, we were shockwaving every 2 weeks per his guidance or his instruction. And I asked him, why are you doing 2 weeks? He said, well, in Germany, you don't go to horses, horses come to you. So if you tell a client in 1 week, they won't come. You tell them 3 weeks, they forget 2 weeks. So that's how we got started. That's subjectively. Since then, Scott McClure, when he was at, I believe it was Iowa State, he found out the mechanism was the stimulation of cytokine release to the area around the injury site. So that is really what we're doing with shock waves. We're stimulating cytokine release. Cytokines seem to release from a site of injury for about 21 days, and then the response fatigues, and the healing level kind of tapers off. So that's why we're shock waving every 3 weeks, and I do it for 3 times. And again, we're just trying to stimulate cytokines. Cytokines are bringing in stem cells. Stem cells are moderating the inflammatory process and kind of kicking everything in gear. So when I have a horse that was fine and has a sudden acute onset of injury, I don't shockwave them right away. I figure they have enough stimulation. I wait 21 days, then I start. Another product that's recently come out is alpha-2 macroglobulin. This is a blood product, much like PRP, and alpha-2 macroglobulin is a protein. I call it a protein mousetrap. It's a protein molecule. When it identifies inflammatory particles, it snaps around them and facilitates their removal from the area. It's really intended for synovial structures like tendon sheaths or joints. Some of my colleagues have been putting them in around soft tissue structures and have been feeling that they have a good response and moderation of the inflammation complex or reduction of inflammation. I haven't used it to that. I can't really speak much to it, but I think there's some interest there, and anything we can put around to moderate or inflammation without stopping healing like a corticosteroid does, I think would be a benefit. There's probably some place for alpha-2 macroglobulin to be used.
Okay.
The other thing that people will use is they'll use lasers. I don't know what to think about lasers. I've read a lot of literature on lasers, and certainly in humans and superficial structures in horses, it really has a nice beneficial effect and really can help with inflammation and really help with improved comfort. So I think that there is really, for superficial structures, lasers are probably good. We have a tendency to class lasers according to, well, they're classed according to laser class 1, 2, 3, or 4. And because we're humans, 4 is better than 1. And really, what classes of lasers refers to potential damage. So a class 4 laser use is more dangerous than a class 3, which is more than a class 2. So if it's more dangerous, it must be better, right? And so you can argue that back and forth, but certainly the higher the number, the more potential thermal injury can be created. So you have to be careful with lasers. There's probably a place where there's some nice regenerative lasers, and they seem like they're quite effective. It's always hard to discern marketing from actual science, but it looks like they're pretty good. Finally, there's a product called ACell. And there's other products out there. I apologize to the other manufacturers, but ACell is a scaffolding product. So this is from the basement layer of pig bladders. So basically you take a pig bladder, scrape all the cells off it, and then remove this layer, and then make a powder out of it, and then you mix it up with some diluent, and then you can inject it into a tendon. And the idea is it forms a scaffold that the stem cells or that the other healing cells that come into the body, the fibrinocytes, have a place to attach to, so they're not floating around. And I've had really nice results with some of the ACell. Initially, I was using too much, and horses got quite inflamed from the injection site, but once we got past the inflammation, they healed well. Since learned to back off the dosing. So ACell, it has a place in my practice for large defects that I think I want scaffolding. So when I look at a tendon, I evaluate it, and if the tendon is a diffuse enlargement with edema, I try to get the inflammation out of it. If the tendon has a defect or a void in it, I usually put PRP in it. If a tendon has a large defect and I don't think the PRP is going to stay there, then I'll use ACell, but most of the time I'm going for PRP.
Okay.
All right.
And I know I know that there's, and we've talked for a little bit now, but we have to talk about client management when it comes to tendons.
Yeah. So, I think client management, so I like to do shoeing changes on these horses. So I'm trying to work with, I try to reduce the tension or loading of the structure. And you can do that with asymmetric shoeing, meaning that the shoe is not equal all the way around. So if it's a deep flexor tendon injury, then I want to try to raise the heels when the horse walks on soft footing. And the best way to do that is to put more surface area of shoe in the back of the foot and less surface area in the front of the foot. So the easiest way to do that would be to put a shoe on backwards or a reverse shoe. Likewise, you could use an onion shoe, or you could use an egg bar shoe with a thin toe. And to see an effect, I put horses on a soft piece of foam and I radiograph their feet, and we put different widths. And what we found is that a 34 millimeter width bar on the side you want wider compared to a 17 millimeter width on the side you don't want, the side you want to penetrate more, was the ratio. So if you're not achieving, if you will get a diminished ratio if you don't follow those numbers. Yeah. So if I have if I want a horse's toe to penetrate more because I want its heel to stay higher and relax the deep flexor tendon, then I'm going for 34 millimeter width bars on the end, and the toe I'm trying to keep at 17. If I have a suspensory branch injury where it's inserting in on the lateral side, then I'm going to put a 34 millimeter lateral branch on the shoe and a 17 millimeter medial branch on the shoe. So when the horse walks on soft footing, the lateral side stays up on top of the cushion, the medial side penetrates into the cushion. I try not to use wedges in these horses because tendons and muscles have a relationship that they like to maintain a certain amount of tension. And the wedge works well for about 2 weeks. Then the muscle says, hey, we need some more tension here, and they'll start tightening up. And then you're right back to where you were, but now you have to wear a wedge all the time. So I really try to keep horses without wedges if I can avoid it. Sometimes you just can't. But part of the shoeing is that I try to have the client take the responsibility of recognizing that this is an important part. Now, for me, the difficulty comes in is they don't need to shoe their entire life. I just try to do it through the healing process. So if a structure is very weak, I'll try to shield it from the excessive loading. Once I get once I see the defect has been filled and healed and start to see linearity on ultrasound, it's starting to look more echo dense, then maybe I'll start progressively getting the horse back to a regular shoe. I might not get all the way back, but I'll try to get it more normal and less extreme. So if he's on a reverse shoe, I might go to a onion shoe type of thing. The second thing we wanted to talk about is if a horse is an older horse and he has spontaneous degeneration or is having trouble healing, I really do a lot of metabolic testing in these horses. And I don't think that pulling a single blood sample and sending it off to the lab is enough. I really think you need to do TRH stimulation on these horses. And the other thing I'm doing more and more is oral sugar test. And that's where you're giving these horses Caro syrup. And then after 60 minutes, you take a blood sample for insulin glucose, and after 90 minutes, another sample. I just hate squirting Caro syrup in a horse's mouth. I get all sticky. So what I'll do is I call the client, I tell them how much the horse should be getting, which is 0.45 milliliters per kilogram. And I have them administer it 1 hour before I arrive. So when I arrive, I pull my samples. I am not sticky. And so I do the mixture of and then I do my TRH stimulation test at the same time. So it's a lot of data, but I think it's really useful. The other part of client management is a lot of people say, well, I ice this horse, I'm still icing. It's a month later and they're still icing the horse. Well, that's probably not what we need to do anymore. I mean, icing is probably very useful while we have active inflammation. We're trying to attenuate some of the inflammation. So, initially we might ice this tendon for a week, maybe 2 weeks. And I probably don't do it much after that, except when it's starting to return the horse to work. And if they start getting a little sore after work, I'll ice it because I think they're straining and stretching the fibrous tissue, and it's remodeling and adapting. So I use that. So clients have to get, I think the key is you really want the client to take responsibility for this. They need to be part of the team. And likewise, the farrier has to be on board. So we have to have everybody together working this. And I think most people, if they understand what we're trying to accomplish, are really very happy to help because they want their horse to get better.
That is probably a great point for us to pause on. I know we could talk about this topic days, weeks, months, because there's so much to go on. But I really want to thank you, Dr. Thaler, for joining me today on this Disease du Jour episode. I know that our veterinary and vet student listeners are going to really enjoy this. And we want to thank our audience for listening to Disease du Jour, and a special thanks to our 2022 sponsor, Merck Animal Health. And we invite you to listen and rate past podcasts of Disease du Jour on your favorite podcast platform. And if you have any questions or suggestions, send an email to me at kbrown, that's the letter K Brown, at equinenetwork.com. Disease du Jour is a production of the Equine Podcast Network, an entity of the Equine Network, LLC.